So welcome to this bite-sized teaching session on adrenal insufficiency. My name is Chris Bidder. I'm one of the paediatric consultants in Swansea. The reason for doing this is because the endocrine team based in Cardiff through their network have identified a significant number of children either known to have adrenal insufficiency or presenting for the first time, where there was a failure to recognise their condition and act quickly in the management. And it has caused harm to some of those children. So this teaching session is part of the response to those cases. It's worth saying that although there are not a large number of these children, their care is very important. In Swansea, all of the children known to have adrenal insufficiency will have open access to the paediatric assessment unit. We'll have an open access letter detailing how they should be cared for, and we'll carry a steroid card with those same care details on. So you've got resources to help you. In terms of causes of adrenal insufficiency, some children have a congenital cause, either due to a primary adrenal problem like CAH, which can present with a disorder of sex development in girls, or a collapse within a few weeks of life, or they might have a primary pituitary problem causing a secondary adrenal cause, and may actually be deficient in a number of pituitary hormones, including TSH, growth hormone, and ACTH, and be on several medications. In terms of acquired causes, Addison's disease is fortunately very rare in children, and we'll talk a little bit about that. All of us as consultants in Swansea will treat children with corticosteroids, and for some children who have more prolonged or higher dose courses, they'll have been provided with a steroid card by their consultant. Brain tumours and their treatment, either primary pituitary tumours or other brain tumours requiring radiotherapy or surgery, can cause acquired adrenal insufficiency because of ACTH lack. This list is by no means exhaustive, but illustrates some of the causes. So in terms of managing known patients, you will have phone calls on PAU from patients known to be adrenally insufficient, and I'd encourage you to always take the concerns of them and their parents very seriously. If in doubt, to bring them to be seen, ensure that they're triaged quickly and assessed as a priority. And I guess the first rule to say is that there are no circumstances where it's appropriate to stop corticosteroids. If patients aren't able to have them orally for whatever reason, either because of vomiting or nil by mouth status, they must have them IV. The second thing to think about is that all of them on their steroid card will have doses for illness, typically double or triple their normal daily dose. And it'll be written down something like this. It's essential that they have those medications either orally or IV, and if you're unsure how to convert the oral to IV dosing, ask for help. Also on the steroid card is more details about which investigations to do and management of situations like low glucose and shock. I guess the final thing to mention is that if you're unsure whether IV or IM hydrocortisone is indicated, there are almost no circumstances where giving a dose of IV or IM hydrocortisone will do harm, and the dose is relatively small, so that the maximum IV hydrocortisone dose of 100 milligrams works out to roughly 25 milligrams of prednisolone in equivalent terms. So if you're not sure whether they need IV treatment, it's safest to give it and think about things later. In terms of recognising Addison's disease, unfortunately, it's very difficult to recognise. It's insidious with a slow onset, with mostly vague and non-specific symptoms. You have to actively think about it and consider it in your differential diagnosis to pick it up. And unless you do that, we will miss cases, and unfortunately children are regularly diagnosed after death with Addison's disease. What I would say is if you do think about it and you want to rule it out, you should do it straight away. You shouldn't leave it for outpatient assessment. You should try and make sure it's resolved before they leave with an early morning cortisol, and if necessary, a snack then test after this. If you have any questions interpreting cortisols, ask the consultant responsible, who can always ask one of the endocrine team. So to try and support care of children on the ward, we've developed a poster which we plan to put at the head end of the bed, highlighting a patient might have adrenal insufficiency, reminding people never to stop treatment, and listing the different emergency doses for different age children. On the back of that is the information taken from the steroid card, which is more detailed, including a QR code that links to the steroid card. Finally, I'd just like to highlight how to get in touch with the endocrine team. We'd like to know about anybody with adrenal insufficiency being admitted. If they're stable and well, it can be the next day. But if there's an emergency out of hours, you can contact the Cardiff endocrine team via the rota at UHW. And I've put the contact details for the members of the team. If you do have any questions, please get in touch. I hope that all makes sense. Thank you.